कब तक आना होगा मुझे?
We'll start in a couple of minutes. Good evening, friends. Welcome to the MAPMR webinar series. We had a very successful first webinar by Dr. Anil Kumar Gaur on advances in SCI rehab. And to continue it forward, today we'll have on stroke rehab. I hand over the dais to Dr. Navita to start the proceedings. Navita, unmute yourself.
Yeah, it was muted from the host. So I welcome a very good evening to everyone, and I welcome on behalf of MAPMR, as Dr. Srivastav has told. This is the second session, and we have with us, all of us are waiting to listen from him, Dr. Abhishek Srivastav. He doesn't need any introduction, but still we have some new PGs, and he's the director of at Kokilabhen Dhirubhai Ambani Hospital of Center of Physical Medicine and Rehabilitation. And his achievements, he has numerous publications. We all know he has created his space in neurorehabilitation, in stroke, brain injury rehab, botulinum toxin. He goes and takes workshops for botulinum toxin, ultrasound guided as well as blinded. He's member at large Presidium of WFNR. He's chair of SIG of Multiple Sclerosis of WFNR. He's chair of Education Committee, Asia Oceania Society for Neurorehabilitation. He is chair Neurorehabilitation subsection of Indian Academy of Neurology. He is secretary of Indian Federation of Neurorehab, and so on and so forth. So he will be delivering a talk on advances in stroke rehabilitation. So we welcome Dr. Srivastav, and now it's all yours. Before starting, I would request each and everyone, they can type their questions and comments in the chat box, so we can take it after the talk. Over to you, Dr. Srivastav.
Thank you, Navita, for a kind introduction. Just share my slides. The slide visible? Thank you. This talk is on basic concepts and advances in stroke rehabilitation. This talk will cover basic principles, the concept of neuroplasticity, how to assess these patients, how to use impairment-based approach on different components of stroke, and some case examples. Stroke, what does it mean? For patient, it's end of the road. For family, it's beginning of burden. For physicians, interventions primarily. For organizations, it's investment. But for a nation, it's loss of people with disability. It has huge significance in amount of money spent in care, both in India and abroad. Always remember, No two stroke patients are alike. They have same MRI, but they behave differently because it all depends what rehab they're getting ultimately. That determine the outcome of those patients with similar MRIs. So stroke can cause multiple impairments, which is now called loss of body structure and function, which can include effects in cognition, in behavior, in speech, language, swallow, vision, sensory, motor, and filter deficits. So our job in rehab is to identify all these 8, 9 components in detail and treat them. They'll be a multidisciplinary team. If you don't treat, don't give them rehab, they can have significant involvement of disability in mobility, in self-care, cognition, communication, and filter domains. And this study was published from NIMHANS very long, 20 years back, that even at 6 months, 50% of patients have significant involvement at 6 months post-stroke. So can we change the brain? When we were studying medicine, we were told that you can't change the brain much. But now we have enough evidence to show that we can change the brain, help of our interventions. So what has changed? If we ask non-physiatrists primarily what is stroke rehab, they will say therapy, therapy, and therapy. But what has changed in last 10, 15 years is multiple things. Neuroplasticity component, impairment-based approach, continuity of care, goal planning, team approach, hyperbaric oxygen therapy, music therapy, decannulation protocols, new technologies, robotics, pharmacotherapy, physician supervised programs. All these concepts have significantly changed the outcome of patients undergoing stroke rehab. The whole concept is to give them enriched environment, to give them enough therapy in a much more goal-directed way using technology and good medical care, so they can get the best outcome possible, the deficit they are having time of stroke. Some basic facts, always remember, there are two types of recovery after stroke. One is spontaneous recovery, which will happen in first 3 to 6 months. The swelling comes down, some reconnection forms. You can even modify this recovery with the help of pharmacotherapy or neuromodulation now. And second is functional recovery, which has no time limits per se. It is primarily based on plasticity and training and primarily based on rehab. Second is neurological rehab is also of two types. One is compensatory. No, somebody cannot walk, we give a stick, he can start walking. It is just adaptation, very well recognized. Second is remediation rehab. Can we restore function by reducing the impairment, those 9, 10 impairments? Can we reduce the impairments to make a person more independent? It was poorly understood, but now enough evidence to show that we can do it now with newer rehab approaches. Take example of acute stroke. Somebody comes to the emergency with an MCA infarction in first 4 hours period. We all know that there's a penumbra concept of penumbra, which means some part of brain is completely dead, some part of brain is partially reversible. You can do IVTPA, burst the clot, or you can do clot retrieval in first 24 hours and can make a person better. It's very well recognized, approved by FDA, and is utilized in many centers now. But always remember, even in best places in the world, only 5% of patients are able to reach in time for these interventions. Rest 95% of patients still are not reaching in time and they need rehab primarily. Also, there are some drugs which can be started in initial first few days, which can improve the language outcome of such patients. Also now coming up very well in literature. What happens in first few weeks to first few months? Brain recruits additional areas to perform new function, or new part of brain takes over function. This potential ability of brain to change in response to a stimulus is called neuroplasticity. That's the rewiring. Some part of brain is damaged, other parts helps. That rewiring is neuroplasticity, And what we're doing in rehab primarily is to somehow trigger that reactivation to happen by two ways. First, by intensive training, be it speech therapy, language therapy, physical therapy, occupational therapy, robotic training. That's called as experience-dependent plasticity. And second, newer treatments like neuromodulation or pharmacotherapy can also help. Also, one concept is called as impairment-based approach. If you identify all these 8, 9 deficits, cognition, behavior, vision, speech, language, solar movement, you treat them all together combined, the outcomes are better. There's a famous cartoon by Ward and Cohen where they've shown that how you can improve motor function after stroke. For example, MC dilatory infarction. This is the parietal lobe capsule being involved. You can do some pharmacotherapy, which is now I'll show you. You can do opposite side RTMS low frequency to reduce the transcausal inhibition. We can do supplementary motor area activation by neuromodulation, brain stimulation. We can do intensive therapy to involve extremity, or we can do CIMT to the opposite extremity. CIMT is approved, therapy is approved, pharmacotherapy is now getting approval. The neuromodulation is currently in phase 3 trials, both for motor as well as cognitive and speech language recovery. People ask, when does rehab starts? We all know this. It is not a separate phase of treatment. It starts day 1 to day 2 post medical intervention. It continues lifelong in some patients. What is also important is the concept of continuity of care, which means when the patient come to the hospital and they are neurologically unstable, they require ventilatory care, they are in the intensive care units. When they are out of ventilator, they are neurologically stable, but still in neurological monitoring, they come to a place called a stroke unit. When they're neurologically stable, needs medical monitoring, have tubes, go to acute inpatient rehab unit. When the tubes are out, they're medically stable, they can come for therapy to the hospital or rehab center called as daycare rehab unit. And those which have minimum deficits can go for outpatient program, a community-based program, or a home-based program. So our job is to ensure that each of our place of work should provide this continuity of care to help our patients. Because many of these patients who have large artery strokes require lifelong rehab interventions. How to assess them? A good paper with Lancet for the ICF model. We know the pathology of stroke, which can be ischemic or hemorrhagic. We do a CT or MRI. Now, if you take body structure function being involved, the impairments, the commonly areas affected can be consciousness, orientation, energy, sleep, cognition, proprioception, vibration, mobility, muscle power, muscle endurance, and structures involved can be brain, cardiovascular system, leg and arm, or shoulder region. Same way, activities which are being involved can be communication, speaking, reading, writing, walking, talking, dressing. And third thing is the participation restriction, which can be adaptation to goods or service, doing your housework, preparing meals, going to work. How can we assess? We all know we do CT, MRI, Doppler, and ECG and EEG for brain functions, but we also require clinical evaluation, require fundoscopic evaluation, chest auscultation. For impairments, we use neurological scales like GCS, MMSC, NIH stroke scale, plus we do Fugel-Meyer assessment, we have to do Western aphasia affectory for speech language, you do ACE or MOCA for cognitive function, check fatigue. For disability, we all know about Feynman-Barthel, very commonly used scales in stroke is a modified Rankin scale and a Frank Activity Index. Plus, there are multiple scales for balance and mobility. Same for participation restriction, very commonly used scale is a SF36, but there are stroke-specific scales also for quality of life which are available. So a stroke patient will require multiple type of assessments focusing on different impairments as well as activities and participation restriction. Now there are multiple impairments. It requires a team of people who can work together. Neurologists and neurosurgeons do the initial part of the treatment. Rehab physicians, nurses, physical therapists, occupational therapists, speech pathologists, psychologists, social workers, orthopedic nutritionists, and so on. All are required because complex strokes need a lot of care. Now, how do these teams work is also very important. We all were trained for medical model of care, but doesn't do very well in stroke rehab. The two commonly used models are a pyramid model or a matrix model. A pyramid model is MBD model of care where one person takes charge of the team, give work to every person and team member, have weekly meetings and take it forward, which is a MDD model. Second is the matrix model where each team member evaluate the person independently, make their own goals, but still meet once a week and take it forward. For LMIC countries where don't they have such advanced models of care, a pyramid model with physiatrists leading the team is the best way forward right now. Now, as there are multiple impairments, the prescription for stroke rehab is an admission or an outpatient has to target 5 major issues. First and most important part, these patients still have tubes, they have medical needs. You should be able to provide continuity of medical care. When their tracheostomy, their catheters, their Ryle's tube, their basic diabetes, hypertension. Second, these patients can develop secondary complications, aspiration pneumonia, pressure ulcer, contractures, UTIs, DVTs, pain, sleep problems. So our job is to identify if they are happening or prevent these complications, and then third, treat the secondary complications. If you can't provide the first two things, these patients are not fit enough for therapy, then they can't go for therapy, and that defeats the purpose. The rehab physician plays a very important role in the first two things, and then plan the rehab with the help of your team, and then provide them training for sensory-motor functional deficits, training for cognitive, communicative, and social deficits, and very important, identify and treat psychological and social issues. So the prescription for rehab includes pharmacotherapy, botulinum toxin, nerve block, corrective casting, special ulcer surgeries, and speech language therapy, solotherapy, cognitive retraining, orthotics, OTPD, social work, and so on. I should be able to provide instructions to all your team members on what do you want for a patient to improve. We call this as 666 concepts. Our patients with moderate to severe strokes at least get 6 therapy sessions, 6 days a week, minimum 6 weeks, to have optimum outcome of care, both in the outpatient and the inpatient program, depending upon their medical needs. Let's see one by one. So when you go see a patient in the ICU on day 2 or 3, whatever, patient on the ventilator, you also see a patient. Always remember, in ICU, many patients are on some medications which are not good for stroke recovery. This concept given by Goldstein called as detrimental drugs: haloperidol, prazosin, clonidine, phenytoin, benzodiazepine, orbital. Request the neurology colleagues if they can change it to a better alternative, which are available now, because they are not very good for stroke recovery. Second, those patients who have GCS less than 10 are in vegetative state or minimally conscious state, who have massive strokes, require decompression surgeries, and they're out of ventilator at least 24 hours, can be started on hyperbaric oxygen therapy. Why? Because this reduces inhibition, reduces inflammation, inhibits apoptosis, promotes neuroangiogenesis, because there are more oxygen in the dissolved plasma in the blood. One of our studies under review have shown that those patients who underwent decompression surgeries post massive strokes, those who got HBOT with intensive therapy, the GOS at discharge was equal to more than 3 to 6% of patients, which means they were living at home without tubes, which is very, very significant. I hope in next 5 or 10 years, we'll get enough approvals for HBOT for such patients. Current guidelines say this can be used in a monitored environment. Second, we have now many older people, sicker people, those with diabetes, hypertension, CKD, cancer, with a stroke. So we expect more complications to happen, and these complications can be life-threatening. They enter with rehab interventions, they retard the progress, more length of stay. You should be able to handle these complications. And current guidelines say that in acute inpatient rehab, in acute rehab, the mortality rate can be less than 2%, and transfer bed to isolation less than 5%. So remember, we are having many more sicker and complicated patients under our care for rehab. You'll be able to manage these patients well, otherwise you have grave outcomes. And complications can be of multiple types. They can be neurological complications like seizures, hydrocephalus, delirium, encephalopathy, depression, cardiopulmonary problems like PSH syndromes, new cardiac attacks, angina, endocrine complications. Hyponatremia is most common, and also have hyperparathyroidism along with that in the PCS strokes, MSK problems like contractures, HO very commonly happens, general medical issues like aspiration, thromboembolism, pressure ulcer, undernutrition, skin problems like pressure ulcers in bladder and bowel. Should be able to prevent, identify, and treat all these things. So make our patients fit for rehab. They can go and do therapy and become better. One very important thing which we see in most of our patients is shoulder pain. Always remember, a post-stroke shoulder pain can be of 5 different reasons, or multiple, or all 5 of them together. Subluxation, spasticity, rotator cuff problems, adhesive capsulitis, and CRPS. And remember, treatment is different for all these 5 problems. Spasticity very commonly interfere in treatment, and if person had a lot of spasticity, the rehab outcome is not good. They can't do therapy much more effectively. We all used to give botulinum toxin, but now current guidance says that some type of instrument guidance is superior than manual needle placement. You can use ultrasound, EMG, or E-stream, whatever you're trained for. Try to use something so you can give a lesser dose, and it's much more cost effective and much more superior outcomes if you use technology. It's level evidence now for that. Third, very commonly thing is neurogenic bladder. We think the stroke patients don't have bladder problems. One study from Nimran Dr. Gupta's paper, we have shown that patients who were discharged at 1 month post-stroke, 90% of patients had neurogenic bladder at 1 month post-stroke. So at least check PVR in all patients after catheter removal. And if possible, if there are persistent symptoms, do a UDS and treat accordingly. With sensory motor functions, we always being asked in the first referral, can we mobilize a patient or not? It's not rocket science. These are nice guidelines, very simply available, free of cost. This says not to mobilize, sit out only, to mobilize. So if you have high systolic blood pressure, low systolic blood pressure, less than 8 GCS, less than 94 saturation, less than 40 heart rate, do not mobilize. Sit out only, it's available now. So remember, primarily it's cardiovascular instability which determines out of bed mobilization. And any patient who is able to sit on day 1 out of bed without blood pressure drop can be sent to stand on a tilt table. Once they can stand on tilt table for 30 minutes for 2-3 sessions, they start standing over ground. Technology also helps now. This is a device where FES is inbuilt in the tilt table. So postural drop is much more less, and you can start standing even more early. Second, Therapy. These patients will undergo therapy, and that therapy can be part of physical therapy or occupational therapy. These are called as physical approaches. Four most commonly used approaches are Bobath approach, PNF, Brainstorm Motor Learning Program. All these patients will require a mix and match of these approaches. No one approach is good. A mix of all is required depending upon patient current stage. Then pharmacotherapy. Are there any medication which can improve motor outcome after stroke? Yes. The most fanfare trial was FLAME trial in France, where they give 20 mg of fluoxetine to all MCT-30 infarction patients from day 7 to day 90. And they have shown significant changes in the MRS outcome. But a meta-analysis of 12 centers later failed to show that improvement. Then came DAS trial, where they give dopamine in chronic stroke patients to improve mobility, didn't help much. Then came TALOS trial, where they've given escitalopram, an SNRI envelope, an antidepressant of about 20 mg per day to acute and subacute stroke patients for up to 3 to 6 months. And they have shown better outcome of motor function. And now actually, European Academy of Physiology has approved this drug to be used in subacute stroke. But they say the dose which can make a difference in motor function is 20 mg per day. Most of Indian population doesn't tolerate 20 mg. So that's a problem with us. But at least we should try it at least 10 mg in most of our patients and look for hyponatremia. That's a problem with this drug. Otherwise, it's relatively safer. There's a trial called as CARS trial, where the drug called as cerebrolysine. It's the only trial which has shown better hand function on ART scale in acute subacute stroke patients. Cerebrolysine is now available in India commercially in an IV form, but it can sometimes cause seizures, so be careful. Escitalopram is a good drug to start in most of our patients. It's primarily an antidepressant, but also had some neuromodulatory effects that help in motor recovery also. Then these patients require sensory motor training. And now a lot of concepts and technology has come in the last 15 years. We'll see in short, how can we reduce that learn, non-use and impairment reduction intensive training. Most commonly used now in thing is lower limb are robotic systems. For lower limb, there are 5 types of systems. Ankle-based, not used now. Stationary FES, not used now. The most commonly used now the exoskeleton-based systems, which are utilized for severely impaired patients. Foot plate systems for mild impaired patients. And now what's coming are the overground robotics to improve mobility. So this is a Locomat from Hokoma. There's a body weight support system with a robot who can make you walk on a treadmill with a differential speed with a feedback. So it has 5 components. It is not passive training, it is active training. On day 1, make a person walk in the air. Let's say walk on the treadmill called nice walk with a biofeedback or augmented. There are now Indian machines also available now in last few years. Any patient who's able to stand for 2 or 3 sessions on overground can be made to walk on the robotic system. Earlier you start, better it is. At least check for EF, check for osteoporosis, check for any contraction and pressure ulcers, putting patient in the machine. So concept is gradually you reduce the body weight support, you reduce the robotic assistance, increase the speed, and patient getting conventional therapy along with that to learn the skill. And gradually you can phase out training on robotics and do more conventional therapy and work down training. Cochrane review very rarely gives evidence in rehab. But Cochrane review says that every 5th dependency in stroke can be avoided if you start training on robotics along with conventional therapy. And always remember, this is only for non-ambulatory stroke patients. Don't use this for a person who's already walking. It's not required. It's primarily for non-ambulatory stroke patients. Same way, upper robotics, multiple types of systems have come. Same exoskeleton-based, end effector-based, only for wrist and hand, only for shoulder, sensor-based systems. Those things that come in the last 15, 20 years. We call it hand studio. That's an army of power. Even patients with day 7, day 8 post-stroke who has enough sitting balance can be made to start this therapy. What it does, God has made hand to use, not to exercise. So you're doing an everyday task on the computer with the help of robotic assistants. Whatever movement you can do, you will do. What you can't, robotic sensors will sense it and give you that push. So it is active assistive training. Every day, there are new setting for a new challenge for you. So gradually, you start doing yourself. Robotic assistance is reduced. When you get some more power in the shoulder, you have to focus on your elbow and forearm. It's called as army of spring. Concept is same. Active assistive training, not passive. Third, when you primarily have hand involvement, called as a medio system, where you can focus only on your different parts of fingers and thumb. Always remember, robotic assisted training for upper limb is always done in conjunction with conventional therapy. You get more movement, but you learn the skill in conventional therapy only. So both work synergistically to each other. And Cochrane review says that patients who undergo training have better ADL, better arm function, better arm muscle strength, and less dropout rates and less adverse effects. So it definitely helps. But always remember, whatever technology you're using, you can reduce the impairment with technology, but function will change with conventional training only. Those who are walking want to walk better. You can analyze their gait by instrumented gait analysis. This person came to us for first follow after stroke, and he says that can you remove my stick? And clearly see he's not bending his knee enough. He's landing on his toes, and we gave him botulinum toxin. And in 3 weeks' time, the stick is gone. He's able to put his heel and walk better. Also remember, we forget sensory deficits. Many patients with stroke also have sensory involvement, and they have potential fallers. So simple device is dynamic posturography. We have published long back. 30 sessions of this training help to improve the balance as well as the mobility and reduce fall in stroke patients. FES is the in thing these days. Olden days, we have FES only for ankle systems. The FES, multiple channel FES is also available. It's a very good device to improve motor power in stroke patients. Also, EMG biofeedback can be combined with FES, also works better, especially for gait improvements. AFO, we all know from previous polio days to our leaf spring AFO to articulated AFO. We even have carbon AFOs now, which are much more lightweight and can definitely help to improve the speed of walking, better walking impairment, better weight distribution. Virtual reality is the in thing now. People actually use games at home now with Xbox. And you can do multiple times and play badminton, table tennis, football for lower limb. And Cochrane reviews have shown that better outcome for arm function and also better ADL with VR training. Circuit training in chronic stroke patient, put them in a gym-like environment and do strength and endurance training, improve the 6-minute walk test, gait speed, when reduce length of stay. It's quite safe in stable stroke patients. CIMT not very commonly used, but doesn't cost anything. The EXCITE trial, it is the most researched modality in motor rehab in stroke patients. Concept says that these patients would have enough wrist extension and 10 degrees of MP joint extension who are fit for CIMT. But even there are now modified CIMT components. The whole issue is if you can use your arm for 3 hours per day, you can reduce the transcallosal inhibition, and that definitely improves the hand function post stroke. We all rehearse our talks. It's called as mental practice. If you rehearse a motor function, it's good for upper extremity involvement. Less evidence, but it's very commonly used now in subacute patients who have some residual hand function. Also, mirror therapy is also very commonly used among mental practice to reduce sensory deficits and neglect, and even hand and ankle function in stroke patients. Then comes NIBS, which is non-invasive brain stimulation. You can do it with two ways by putting a magnet, which is called as repetitive transcranial magnetic stimulation. Second is TDCS, which is transcranial direct current stimulation. Both are now utilized in different concepts, and the most commonly used systems are low frequency RTMS to the opposite motor cortex to reduce the transfer inhibition in hand function. Now there are studies, recent transport trial has come from Wayne Fang group, and they have shown that TDCS is non-inferior to physical therapy. So you can combine now both TDCS and RTMS before your therapy, even with while the therapy sessions. They're even doing this while the people doing robotic training also. So NIBS, both RT and TDCS are now in phase 3 trials for motor function, for speech, for swallow, and cognitive deficit post stroke. In next 5-10 years, you get the FDA approval also for that. The European Consortium has given the approval for both of them to be used in a controlled environment. Then some patients who have significant involvement, especially brainstem stroke, where they have no arm function lost, a simple BCI device like a EEG haptic device can be utilized, where you can use the neck movements to target the computer screen and can communicate and write. And now we have very advanced EEG-based BCI systems which are helping the patient in chronic stroke, mainly for hand function. Second is dysphagia, and we all know that aspiration is the most common cause of death in acute subacute stroke patients. So all stroke patients has to be assessed for dysphagia within first 24 hours if they are conscious. How? The multiple screening scales available, your nurse can be trained, your residents can be trained. We formed our own simple assessment scale where we assess patient cognitive status, behavior status, their motor speech, their language, check all cranial nerves, 7th, 9th, 10th, 11th, 12th, and then do per oral trials if they are fit, look for their oral stage mechanism, pharyngeal stage mechanism, and then decide can you start oral feeding or not. You can use 3-on sorrow test, you can use toast test, you can use Gauss test, multiple tests are available now. But remember, we have to screen all these patients who are conscious. And then we have to start them on a proper solo therapy regimen program that can include compensatory things like postures, consistency of food, voluntary control type of concepts, or rehab approaches like LSVT, electrical stimulation, or vital stim called as NMES, or combination of different maneuvers which can be useful. If you have speech language solo therapy is very good, you can train OTs or PTs also do basic things for that. Then comes a patient with tracheostomy, and we all were afraid of tracheostomy getting trained. Always remember you can decannulate most of your patients through a simple protocol. This is tracheostomy, which is a cuff tube. There's a cuff here. This is a thermovent. You can deflate the cuff and give some colored liquid. That's called as modified Evans blue dye test. The no colored liquid in the suction, it means patient is able to clear basic saliva, and that's a positive dye test, which means there's no signs of acute aspiration. If you can do that, you can put a valve. It's a one-way passive speaking valve. Deflate the cuff, put a valve. If person is non-aphasic able to speak, if not, He will not be able to speak, but he can strengthen his muscles when he's putting the speaking valve. Make it 10 minutes, 3, 4 times in a day, gradually increase it to 24 hours in a day. If you achieve that, you can do a video fluoroscopic swallow study. All our X-ray units have fluoroscopy. You can take patients there, train your therapists or residents in doing it, give them 3 consistencies, liquid, solid, and nectar thick. You can simply see it here. This is the laryngeal vestibule. If it goes straight here, that esophagus, if it comes in front anteriorly to the trachea, it can be aspiration penetration. There are PAS scales, ASHA scales to quantify level of aspiration and penetration. And person is able to pass that, and it definitely showed that he's able to eat. You can initiate feeding with tracheostomy, or you can decanate them very safely. So there are some dichotomy. What is better? This is fluoroscopic swallow study. Now we also have bedside fees. This is an endoscopic study. Both are good, but there are different indications for that. Fees can be done bedside, no radiation exposure, but you can't see the oral stage and you can't actually visualize the swallow. Versus fluoroscopy, you can directly see all 3 stages: oral, pharyngeal, and esophageal stage. You can even assess the different compensatory maneuvers or swallow maneuvers while doing FESS to know which one helps the patient. You can also see the esophageal sphincter opening in VFSs. Only issue, patient has to be taken to the fluoroscopy suite, you to add barium to the food, and this radiation exposure. In very sick patient in the ICU, if you can do a fees, but in stable patient who is planning for decannulation, VFS is much more better than fees. Also, technology is helping. It's called Vital Stim, the FDA approved device. They are doing neuromuscular electrical stimulation. You're utilizing the intact local pathways to stimulate muscle. This is not pharetic stimulation. So you can use vital stim, especially in patients with PCS stroke, even using patients who have tracheostomy, upper tracheostomy, to improve the strength of the pharyngeal muscle. It helps in decannulation, also people to eat better, especially in PCS strokes. Some patient PCS strokes have this thing called as UVS spasm. Picopharyngeal muscle is the sphincter of the esophagus. Swallow reflex happens when food goes to the back of the tongue, the UVS opens. But in PCS strokes, this is lost. So only by EFS you can pick it up. If you find this, you can give botulinum toxin with ultrasound guidance to the area, cricopharyngeal muscle, and you can see result within the next couple of days, and you can start eating after a few days. And this works. This single injection works for life. We never have given it again in last 10 years in our practice. So, but you should be able to identify these patients. They keep on spitting saliva whole day. They can't even swallow their own saliva. So always pick up these patients, and then you can use technology and botulinum toxin to help such patients. Also, many people ask, is there any formula for decannulation? Yes, the formula for decannulation. This is a protocol being published by Italian groups long back. Look for voluntary cough, look for reflex cough, TT capping, swallowing instrumental assessment, dye test, number of tracheal suctions, do airway patency assessment if possible, level of consciousness, look for saturation. You can decannulate 80% of the patients, even those who are in vegetative state for this specific protocol. People can also have aphasia, which means both speech and language can be involved. So aphasia can involve comprehension, expression, reading, and writing. To look for fluency, comprehension, and repetition. It can be anomic aphasia to global aphasia and start speech language therapy. There's a cartoon to show what therapy to start, but most of the patients with left MCA generally have a Broca's aphasia, which will require a technique called as MIT, which is using music to speak. And different approaches can be speech language therapy, music therapy. There's also something called as CIAT, constraint induced aphasia therapy. These patients have some ability to speak, but they start using gesture communication. So if you put them in a group and say, don't use gestures, only speak, start speaking better. Also, Cochrane review says that in long term, a trained caregiver provided speech language therapy is as good as by speech language therapists daily. So identify caregivers, start training them. And next comes music therapy, which is called as MIT now, which helps people to speak better, doesn't cost anything, train the caregiver. And yes, pharmacotherapy also has a role in post-stroke aphasia, especially patients with motor aphasia. You can try a drug called as memantine, and it is a antagonist, 5 mg OD, 5 mg BD, 20 mg every day, full dose. People who have Wernicke's aphasia, sensory involvement, try a drug called as donepezil, again 5 mg, HS to 20 mg in a day. Memantine can trigger seizures. Donepezil can sometimes cause drowsiness. Start slowly. And remember, if you start these drugs and combine speech language therapy, we have patients who were global at 3 months, became Wernicke's at 2 years, became Broca's at 6 years, now still better. And the person called Gandolfi in Italy, he saw one patient for 25 years with MCA stroke, with aphasia, and he documented how every year patient was better if he was trying basic therapy approaches along with medications. Last, the cognition and behavior made up to two-thirds of stroke patients have cognitive deficit in the beginning. About one-third develop dementia. And always remember, there's a mix of different things. Patient can have post-stroke mood disorder, they can have post-stroke depression, they can have cognitive impairment, they can have vascular dementia. All these things happen together. So our job, also some patients, we have published that one patient had supernumerary phantom limb. She says, I have 8 upper limbs coming out of my body after a stroke. One third of strokes are depression, both in acute, subacute, and chronic stage. So identify cognitive deficits, identify depression. If you don't do that, the life is not meaningful for such patients. The QL is much more worse in such patients. So do cognitive assessment, do MMSC. MMSC is not very good for stroke patients. You can use MOCA, which is really available, or an ACE test, Edinburgh examination. There are also software called Cognistat to assess in detail, and then put them on cognitive rehab with the help of an occupational therapist or neuropsychologist. Drugs also help to some extent in such patients. Let's see some cases in short. Do I have 5 more minutes, Navita? This is about 12 years back. The family came to us with such MRI. This is my son, at 20 years old. He lost consciousness, into a ventilated, underwent decompression surgery. What to do? It's a big ICS stenosis, big global ACMC. In fact, okay, he's 20 years old, 1 month, he still was trying. Transferred to work for the rehab. At that time, he was awake, alert, following simple command as aphasia, TT, dysphagia, plague, RT. These patients require all these things. Mechanism of stroke, cholenerology colleague, secondary prophylaxis, antispastic medication, botulinum toxin, donepezil, memantine, fluoroscopy, decannulation, USG, PVR, splinting, physical therapy, occupational therapy, solo therapy, speech therapy, better training, family counseling, all are required. And you can see here, this is how he was when he went the left brain, and at 6 months he's like this. He improved further. He joined his college back at 4 years post-stroke. Now he works himself. Has mild hand function deficit, but he can speak, he can eat, he can walk, he can work also. Another lady had a postpartum ischemic cardiomyopathy, 15% ejection fraction, with a scan like this. She was told, don't move, you will die. Such a poor EF. She came to us a month post-stroke, spent many months in the hospital. These are functional MRI at discharge. You can see these are supplementary motor areas for hand and ankle. With intensive training, we're able to stimulate the supplementary motor area to take over function, and that's how she was at discharge. She became so better, underwent heart transplant at 4 years post-stroke, and now completely independent in work. Lives in India, Maharashtra. Another guy with an APLA syndrome, DVT, massive hemorrhagic stroke, nothing in the left brain. He now helps his father in his business, drives his own car, and lives with his family. Another guy was running a marathon, had a massive MC-dilatory infarction, underwent decompression surgery, also went to walking. Now even the walking aid has gone. He's completely independent now. We also published that patients with stroke in India, many patients are discharged from hospitals. They are therapy naive. They never undergone rehab. These patients were 6 months to 10 years post-stroke, with about a duration of 2 to 3 years post-stroke. We train them for 1 month, 1/3 learn to walk again, because all of them have some power in hip and knee. Because of sparsity and lack of rehab, they were never trained to walk. We have a unique population in India of therapy or rehab naive patient who can be helped in chronic stage also. Some take-home messages. Always remember that physician supervised stroke rehab programs who work on MDRA team, regular meetings dedicated to rehab, do better than those without that. And we also know that in first few hours, we can reperfuse the brain by IV TPA or by thrombectomy. In first few days to week, swelling starts coming down, you find some improvement. In first few week to first 3 months, brain tries to change itself. That dies down by 3 to 4 months time. That's why people conventionally say that there is no more recovery after 3 months in stroke, which is actually wrong. If you start intensive training protocols in the first few weeks, you get something new, which is training induced neuroplasticity, which can happen for first few months up to years also on specific domains or impairments in such patients. So when we were told 20 years back that stroke is just rehab is primarily compensation. Can't walk, give stick, can't talk, teach sign language, can't eat, put RT. That was disability management, just compensatory strategies. And that further caused learn non-use. We only focus on the disability, not on the abilities. And we neglected the impairment. Current focus of rehab is to treat the impairment to prevent disability to happen. If you try it well, if your brain is amenable to intervention, many patients will change for better outcome. Thank you very much.
Thank you, Dr. Abhishek, for an excellent presentation. And this is what we do, comprehensive rehab, and I'm sure everyone has have many questions, and now it is open for the questions. We'll take questions from the chat box. I can see few of the questions. You can type your questions. I request everyone, if you have any doubts, any questions, you can type it in the chat box. So the first question is, what's the most common bladder type you have encountered post-stroke as per the urodynamic findings?
With the study I was quoting from Dr. Gupta, I was a co-author in that. It was 1 month at discharge. 90% of patients had retrosal overactivity at that time. So patients have atonic bladders in the beginning, but when the catheter comes out and the tone starts coming back, they do retrosal overactivity also. So look for both the things. Check a PVR, and then If patient has more urgency and they're passing fully, but they have urgency, to put them on a anticoagulant medication also.
Yeah, that was a continuation of his question, that how do you address such issues? For example, if I encounter hypercontractile bladder with no spontaneous voids.
So you start a cholinergic drug, bethanechol, start 25 mg PD and go up to 150 mg per day. But remember, it's a cholinergic agent, can cause bradycardia, lot of issues. So monitor the side effects, but start bethanechol gradually up to 150 mg per day, and then also add an anti-allergic agent along with that, and then give a trial of void for at least about up to 3 or 4 weeks.
Thank you so much. And the next question is how early we can take patients for HBOT?
So the protocol we use is those patients who are off ventilator for at least 48 hours. One. Second, those who have blood sugars more than 100. And third, they are having hemodynamic stability, no fever. And fourth, they can manage at least 1 hour without suction from tracheostomy. If those 4 parameters are okay and there is no COPD or no middle ear involvement, these patients are fit for HBOT.
Which can be taken as early as maybe
48 hours post.
48 hours post. Once the neurological is stable.
Yeah.
Thank you.
Actually, we only use it for patients who have disorder of consciousness. Those who are GCS less than 9. We don't use for conscious patients at all. So most of these patients actually have brain surgery before that, and they require ventilatory care. And then they are out of ventilator 48 hours, they're transferred to a stroke unit after the ICU. And then we observe for a day, and then we start next day if they're stable.
Even there are now HBOTs with the facility of ventilator going in, so we can start. So what you were saying, 48 hours, then even on ventilator we can start HBOT, right?
Yes, there are systems available now which are ventilator compatible. We have no experience with that, but systems are available now broad. I hope we will have one in future and we can start in the acute stage also.
Okay, thank you. And the next question is from Samantak Sahu. Any particular thing we can include in the nutrition of patients in acute stroke rehab, specifically in tube feeding, and that can improve outcome?
Actually, all our patients are seen by a dietitians, nutritionist every day, but recommendation says that you should give enough protein, fats, and carbohydrates, one, enough macronutrients along with that. Most of the diet formula diets sometimes doesn't contain essential fatty acids. So only proteins are not enough. You have to add fatty acids also and macronutrients along with that.
So to add to that, is there any role of doing the total protein and the levels of albumin so that we can help them if they are low on that protein? So if you're talking of amino acids, then we can, if not in the diet, we can infuse through IV.
Yes, definitely. We should keep 1 gram of protein per day in the beginning as such. And after a week of tube feeding, always check the albumin. If it's less than 3, you have to give some IV alternate days albumin. If it's more than 3, you can add more supplements. You can go up to 1.5 grams of protein per kg body weight if there's no renal impairment.
And the next question is about swallow. So what is the minimum level of consciousness when we should start swallow evaluation and trial? Again, Dr. Sahu is asking this question.
There are 2 things. One is detailed swallow assessment. So a patient who doesn't have a tracheostomy, one, and if he is conscious, you can do assessment on day 1 also. But somebody who is not following commands, you can't start oral feeds. But you can start swallow therapy for them. So always remember, swallow evaluation is done in conscious patients primarily, but swallow therapy can be started even on vegetative state patients. You first try with dry strategies, work on training to input the spontaneous follows, and gradually thermal stimulation, and then gradually you can start therapeutic trials, giving some drops of water, and then take it forward accordingly.
Yes. So maybe when we are sure that he's swallowing with the tracheostomy, a dye test can help us, and then we can start the swallow, continue with the swallow, right?
Yeah.
So the next question is from Ansarul Haq. How will you manage post-stroke shoulder pain?
Nabita is better than me to answer that question. but conceptually, we have to look for those 5 things. Treat subluxation by a simple thing to keep your shoulder propped up. Look for spasticity. Mostly people have worsening bad spasticity of shoulder adductors and turn rotators. If it's too much, causing more pull, give medication or botulinum toxin. Third, do a shoulder screening. If they have associated cuff involvement or capsulitis, give a suprascapular nerve block. Fourth, if they have a shoulder hand syndrome or a CRPS, give them a seated ganglion block. So all these 4 or 5 things have different components. Some patients have all 5 things together. So at least give a brace in all the patient to prevent subluxation. One, do a shoulder screening, identify the cause, and then give medications, botulinum toxin, SSNB, or ganglion block accordingly.
So I would like to add in that, yes, once you start the rehab and the patient comes for rehab, you're using the shoulder more and more. So the strategies you should tell your therapist that what should be the right way. The positioning is very important, and overhead activities in the first week should be avoided. Second thing, yes, we should go for the shoulder brace so that we don't want the subluxation. If it has happened, we don't want it to increase further. After the screening, because if we don't treat the post-stroke shoulder pain, that is when it develops into CRPS. So we have to early in stroke, remember early intervention is the basic. If we cannot wait for 2 weeks because the patient is for rehabilitation, give for 3-4 days. But if you identify the cause as a tendinopathy or a tear, do not wait with medications because they won't wait for the pain. If they are in pain, the rehab will not happen, and you are losing time and days for them as they are coming for therapy. So plan for the injection like the SSNB, suprascapular nerve block, and if you find some bursitis, you can do that in the same go. And yes, if there's CRPS, so in the early stages of CRPS, even the post-stroke shoulder or the suprascapular nerve can help in reducing or reversing the CRPS. If not, then go for stellate ganglion block. I hope that answers the question. The next question is from Dr. Shweta Gawande, and she's asking about post-stroke psychological problems. Can they appear even after 6 months post-stroke? And even if there are minimum motor deficits at the time of stroke?
Yes, always remember which part of brain is involved. So right hemispheric strokes, especially AC-MC territory, will have some frontal lobe involvement. So they will definitely can develop depression in future. Second, can be reactive depression. Patients have minimum deficits, but they think they're not as good as they were earlier. So every patient has to be screened for cognitive problems and depression before discharge. That's one. And second, when they come for follow-up, don't only look into motor problems, look into the invisible disability of cognition and behavior. If you ask 5 basic questions, you can pick it up. Are they depressed or not? Do basic MMSE screening. So these 2 things should be done because these elderly patients can develop dementia also. And adult and elderly both can develop psychological problems at any times during their follow-up. So screen them for both depression and cognitive abilities in every follow-up.
Dr. Sahu is asking, what are the newer options of DOC? What are the newer options in brainstem strokes or TBI, specifically severe DAI?
DOC.
There are 3-4 questions.
So basically, what's new for DOC? What's new for DOC first is called as multisensory stimulation program or coma stimulation program. Initial evidence was to do it twice in a day. Now the Mega et al. Have shown that if you do intervention or stimulation 5 times in a day, better than 2 times in a day. So every patient's family has to be trained for multi-modality sensory stimulation. One. Second, music therapy. Music can stimulate multiple parts of the brain. The big stimulus also helps. Third, pharmacotherapy definitely has a role. Amantadine has been shown to change VS to MCS in such patients. In NEJM paper, in RCT, always start amantadine. Fourth, if you have HBOT, if patient is in VS or MCS, first 3 months, definitely add HBOT also.
Dr. Manisha asks about what measures should be started for functional recovery after treating spastic muscles with Botox. Is FES helpful?
Yes, if you are giving botulinum toxin for a goal to improve function, for example, if you're giving it for wrist and finger flexors, and you hope that there are some movement in the wrist finger extension, you have to start intensive therapy, which includes stretching of the injected muscles, facilitation of the extensor muscles, and FES definitely helps to improve the motor function. If the motor function improves in the opposite muscle, they'll be able to use their hand in a much more effective way. So yes, FES is an integral part of the rehab if you are giving botulinum toxin for a goal for functional improvement.
Dr. Sumalata asks, do you have any experience with injections of Sovateltide for ischemic stroke?
No, we have no experience.
Okay, so moving on to how we plan for robotics training.
So robotic for lower limb, as I told, if you have severely impaired patients, you need a system of exoskeleton. That's one. And second, guidelines say use it for non-ambulatory stroke patients. That's what we do. So any patient who is able to stand on the ground for at least 2 or 3 sessions with no postural drop, has EF beyond 20%, has stable blood pressure, has no osteoporosis, no major wounds, no contractures, can be started on training on robotics for the lower limb. This can be day 10 post-stroke also. For upper limb, when there is no power in the upper limb, they can just trigger the shoulder. If they're able to sit, have enough sitting balance, have enough cognitive abilities to understand, have enough visual, not much of neglect or sensory inattention or visual deficits or hemianopia, you can start at day 7 training on the upper limb robotic systems.
Dr. Ghosh asks about how common is post-stroke mania in subacute stroke stage and how do we manage it?
Post-stroke mania is not very common. Post-stroke depression happens in 1/3 of all stages of stroke. If you have post-stroke mania, better to involve a psychiatrist. But the drugs are of 2 types. One are antipsychotics and second are mood stabilizing agents. Commonly, antipsychotics are olanzapine and quetiapine, which you can start as a low dose. And second are mood stabilizing agent, which is valproate or new analog called dichorate ER. You need a combination of both of them. Third, they can be very aggressive. You have to isolate them, put them in a cool, calm environment, use low environmental stimulation. along with pharmacotherapy can help.
Dr. Arindam asks about post-stroke shoulder pain in CRPS, post-stroke shoulder hand syndrome. How superior is stellate ganglion over oral steroids if no contraindication? It's always superior.
In my clinical experience, I used to give corticosteroids a lot when you were not doing ganglion blocks. One. We also give a lot of indomethacin in those days, or a combination of both. But they work partially. If you have severe CRPS, as Navita told, if you have mild CRPS, these medications will help. But if you have severe CRPS, ganglion block is much superior to corticosteroids.
Yes, if you have the facility of doing a stellate ganglion block, I would suggest don't use corticosteroid even in pulse dose. It's better to do a stellate ganglion block. The second question is what rehab options we have in case of post-stroke gait instability and postural instability not responding to syncope. Means he's asking about the secondary Parkinsonian features or in stroke. This is what I gather about. So even if you maybe in the cerebellar strokes and
so syncope is not used for gait instability. That's the first thing. Many patients with intracerebral hemorrhage can have extrapyramidal syndrome with both dystonia and rigidity. So in such patients, those who have massive rigidity, you can start syncope. Those who have dystonia, you can start triaxiphenil. But if you have primarily instability because of cerebellar involvement, there is no medical intervention. Evidence says that task-specific training, treadmill training, coordination exercises, balance training can help. But some patients have pusher syndrome, where they fall on one side, which is right parietal lobe involvement. They are very difficult to treat. They require a lot of training, a lot of therapy with visual feedback to improve their pusher syndrome.
Thank you so much. The last, yes. So, so I think so. We have the last comment and a request from Dr. Sahu that please take a class in future on ultrasound guided Botox for swallow disorders.
The Dr. Navita does request her for that. I don't do. I do.
We'll definitely do a workshop for that because we do cricopharyngeal injections, and we'll take that. Now, I think so. Nitin is answering because he has some experience with the neurologist. They have used Sovaltetide and day 1, day 3, and day 6.
What I will say. So I'll tell you.
Yeah, this is what he says that there is no personal experience. Actually, this is you go ahead and answer because the neurologists they use it a lot.
I think there are 3 drugs which have come up, which is one is Sovaltetide, which is Tyvalzi. There is one paper which shows it helps. Another drug is Centrivive, which is given for 3 months. Now, both these drugs, Tyvalzi is an injectable form. Centrivive is given orally for 3 months. I have seen at least, I have never prescribed it, but many of the patients I have seen who are on these drugs, and I have not seen much change. But for both these drugs, there is one RCT. That's why they have a DCGI approval.
Yeah, it has enough.
So as per DCGI requirement, if you have one RCT to show, they mostly give the approvals. I have no personal experience of using both the drugs, but I think at least 50, 60 patients who have got Tyvalzi or who are on Centrivive, but I have not seen much changes in them.
Okay, someone is asking that do you usually give Botox injections for bladder spasticity post-stroke? Yes or no, but and if, how effective is it?
Generally, botulinum toxin for strokes is given in patients with spinal cord lesions. For stroke patients, the medications mostly are enough. And in our hospital, the botulinum toxin for bladder is given by urologist, not by physiatrist. And in my experience, for last 18, 19 years here, we have never required our stroke patient to undergo intensive botulinum toxin. Medications are enough in most of the patients. In some people who have major strokes and they're still like one boy who had a TBI actually, they called me yesterday. It's 10 years post brain injury. The boy is in minimally conscious state and he has persistent leakages on the SPC and he can't tolerate oral anticholinergics. It causes constipation. Such patient can be a candidate for intravesical Botox, but generally it's used very rarely.
Thank you so much. I think we are finished with the questions and the comments, but it was really very interesting. We had so many participants today that we were full, and we are very sorry for those who could not join. We will send the recordings. We promise to send the recording of this talk on the WhatsApp group. And the next session, thank you so much, Dr. Abhishek. This was really interesting and interactive. And the next session is we again invite everyone on 10th of July, which is our third session, which is from our secretary, Dr. Amit Mamre. This is very important disability assessment and certification for those who are practicing and for the PG students, because there are so many questions, so many gray areas in the disability assessment. So that all will be answered in our third session. Today was really very interesting, and everyone is thanking Dr. Abhishek that it was a very good webinar, and it was very interactive. We look forward for the next session, which is on 10th of July. I'll keep on reminding on WhatsApp. So do join us in the next third session. Thank you all for joining, and thank you, Dr. Abhishek, for a wonderful session. Have a good night.
Thank you. Thank you.
Thank you so much.
Thank you.